Welcome everybody. I should abbreviate that bio. Anyhow, I'm really pleased to be here, and this is, I think, an extraordinarily important topic, and many of us that are doing clinical work will come across people that experience various sets of these symptoms. Before I begin, as with Jorge, I also would like to acknowledge the traditional owners and custodians of this land, past, present and future, and acknowledge their struggle for justice. So I'm just going to bring up the slides for today. So I think as we approach sort of this topic, what's actually emerged over the last 30 years is three different clinical traditions have all started to converge, where we've understand just the way in which trauma is so integrated into many people's experience of psychosis. So, you know, the first, I suppose the first area that many of us might have come across some of this work is you know, really in the trauma field and documenting these post-traumatic psychotic presentations, which have been sort of basically documented right back from the early research amongst torture survivors. And, you know, from the very foundation of STARTS, there's always been a cohort of people presenting with horrendous trauma histories, but that combined with very complex psychotic presentations. But then I think, you know, there's been a whole nother strand of research, which is coming out of the study with schizophrenia and psychosis spectrum disorders, where gradually over time, the critical role of trauma in the phenomenology of the symptoms, but in their etiology as well, has emerged over the last, you know, years, and is now has a very powerful evidence base. And I think the last tradition I'd like to name, and I'll sort of cycle back to it today, and it's reflected in my title, is just this overlap between dissociative disorders, which all of us, you know, understand as trauma responses, and psychotic symptoms. And that overlap of those conditions is much more complex than many of us have realized. So firstly, I want to just start with our own field, the trauma field, and what an enormous battle there has been to get adequate recognition of these more severe traumatic presentations. So really, at least from the 1990s, there's been this consistent pattern of research that have identified trauma-related psychotic symptoms in PTSD-exposed individuals. And the early research was actually undertaken, especially with the returning veterans from Vietnam, with combat veterans. But then it started to expand to survivors of severe and prolonged childhood trauma and similarly severe and prolonged sexual abuse. And we also saw this documented very early amongst torture and trauma and hostage survivors. And in fact, one of my colleagues working with STARTS at the time was one of the first to write up some of these complex cases, Derek Silov and his colleague, Dr. Chen. Just very recently, and I'm going to show you some of these results, has been a very comprehensive review from a torture and trauma service of these presentations. So I might just move on to that. So this is from the Danish Refugee Psychiatric Outpatient Clinic, and many of you may well know our collaborators here, especially Jessica Carlson, who's been a frequent visitor to STARTS and a collaborator. They recently undertook a review of 627 clients attending a service very similar to STARTS, in fact, a multimodal refugee torture and trauma service. Perhaps if there's any difference, there's probably a higher level of psychiatric psychiatrists based at that, which may influence some of the stats I'm about to present. But they essentially found that 30% of the treatment-seeking refugees were presenting with this thing, PTSD-SP. So that's post-traumatic stress disorder with secondary psychotic symptoms. So this is not such a rare and infrequent presentation, and brings, many refugees present with these complex conditions, and probably I've repeated that point there, but one of the perhaps the odd things in that study was that it was the comorbidity of depression rather than trauma that predicted PTSD. Now, I think one of the challenges, of course, is that the trauma load of so many of the people that we work with as torture and trauma specialists is very high. And so we already have a group that have an extraordinary history of trauma. And I think what this shows is that the overall evidence isn't that it's just a dose response, so that the more severe the torture and trauma is, the more likely it is to present as a secondary psychotic feature. What we seem to get is that some people experience their mental health impairment through this domain of symptoms, and some people have other aspects to their care. I will show some research a little bit later, which shows a little bit variation on that. So, this is really, despite all this evidence over a very long period of time, there still isn't a diagnostic category that's available to us to describe this. There was a very strong push to get into DSM-5, for example, to have a psychotic subtype, like we've got a dissociative subtype, but that didn't get endorsed. A very recent review has again shown that the evidence that a certain cohort of people have a psychotic component to their trauma presentation, and the origin of it is post-traumatic. I now want to sort of flip to the other tradition, and this is research that's primarily undertaken with people presenting with psychotic illness. And probably the first thing that became very apparent is how horrendously traumatic the experience of psychosis is for individuals. And most of us listening to this today could do a very simple thought experiment of what it would be like to have your freedom taken when you're have a police administered admission to a psychiatric hospital. They're very scary environments, and there was this movement in the Netherlands called the Hearing Voices Advocacy Network, where a lot of people shared their horrendous traumatic experiences of having psychotic disorders and what a confusing and difficult time that is. And of course, as a community and a society, we've decided to suspend some of the human rights of people with severe and persistent mental illness so that we can provide treatment and care. But the subjective experience of that is having your liberty taken from you in often a very forcible manner. So the first thing that became clear was how traumatic having psychosis can be. But then as more exploration came, often the content of the voice hearing that people have and the nature of their psychotic experiences are very strongly related back to traumatic elements of their own lives. And sometimes the voices actually even assume the identity of past abusers. Now, this is a very different understanding of psychosis to the traditional model. The traditional beliefs about psychotic experiences is that they're effectively discontinuous and unrelated to normal experience. There's this long notion held in psychiatry and mental health, for over 150 years of a psychotic neurotic distinction. that these are two completely different constellations of symptoms. Delusions have traditionally been conceptualized as beliefs that are completely unable to be weakened by evidence and refutation and support and mentoring even. The traditional approach to, say, auditory hallucinations is that the content of the delusion is largely insignificant and irrelevant. All that matters is that they occur, and that once they've been identified, the person would then get psychotropic medication and maybe psychosocial support. But never traditionally has it ever been considered that people might need some counseling and support for the trauma associated with their psychotic experiences and the reliving and the intrusive nature of them. So, if you take this, once upon a time, delusions were considered to be empty speech acts. But this new model has emerged, and it's really probably the psychological formulation of psychosis, where that old model of seeing the difference between psychotic symptoms and symptoms like depression, anxiety, somaticization, seeing these as very different domains really doesn't hold anymore. In fact, we know, for example, that psychotic experiences are quite widely distributed in the general population. During times of grief, anywhere up to 1/3 of people experience voice hearing. So these experiences aren't discontinuous with everyday life. They're part of the common human experience. And so this new way of understanding trauma has emerged over the last 20 years, where we now start to try to think of psychotic symptoms as understandable exaggerations of normal function, that they have an adaptive origin and they have a meaning, and they're not exotic symptoms superimposed on top of personality. And that, they may appear to us bizarre because we don't have the context of the lived experience and the psychotic experiences and perceptual disturbances that a person is having. But if we did, then much of what they're experiencing might make sense to us as well. And that really these are distortions and exaggerations of certain, psychological functions, maybe with some eccentricity, but they very very much impair social functioning. Now that was initially, that sort of new model first came out in the actually very late 60s, but it's gained a lot of ground over time, especially as we've seen the wide foundation of many psychotic symptoms, particularly in times of distress. Most importantly is a growing realization that the content of delusions and hallucinations is psychologically meaningful and is a brute fact or reality that people live with. And it's not just a symptom to be treated. It's an experience that actually also needs to be processed. I think the other thing that has emerged in this tradition over time is the traumatic pathogenesis, or the degree to which trauma, firstly, is one of the strongest contributors to mental disorder globally. So there's a statistic that they use, something they call the attributable risk. Now, the attributable risk for most mental disorders from adversity and trauma ranges between about 10 to 40%, and in some cases 50%. So when you think of the prevalence of mental disorder globally, trauma emerges as one of the major global causes of mental disorder. And this has emerged to be particularly true for psychotic conditions. So now repeated studies have shown an association between childhood adversity and psychosis. When you do both prospective research and retrospective research, you find much higher trauma loadings on children and adolescents who develop psychotic conditions later. So trauma as a common cause, a common stressor of perhaps some vulnerability is now emerging as a very powerful re-understanding of what psychosis is. More recently, this research has really advanced to the level where we can really see that there's a dose-response effect here, that as the severity, this is at a population level, you know, the research I talked about before in the Talk to Trauma service, you've got a whole cohort with horrendous trauma exposure. But when you look at a general population, it's those individuals with multiple adversities that are greatest risk of developing psychotic conditions. And you see that clustered in their lives. And I want to show just how important this is. And I know I'm coming at this from different angles, but it just provides a context, because often we'll think, well, we're working with people who torture trauma survivors presenting with psychosis, but many people presenting with psychosis have these kinds of horrendous trauma histories as well. So this is just research again in the psychotic sort of schizophrenia spectrum research tradition, looking at about 636 patients who've received very intensive assertive community treatment, which is the gold standard. And they found that child maltreatment in their history was related to poorer outcomes in psychotic disorders. So just as we know in many other areas, when there's horrendous trauma histories, it provides a very complex trajectory in response to rehabilitation and care. And they found, perhaps concerning, that these poor outcomes increase with illness duration and with age. And it is stronger in schizophrenia samples, where this association between adversity and trauma is also very strong. So I want to, in thinking about how we approach people that we encounter in our practice who present with psychotic symptoms, I want to draw on initially the CBT approach to psychosis and voice hearing. And this has really been a revolution in the way in which we approach care of people experiencing psychosis. And it's changed forever, I think, the way we think about it. Not many of us think of CBT as a human rights intervention, but ironically, in this case, I had a chance to run a Voices clinic, and I found that people who came to the clinic, and that many of them had psychosis for 20 or 30 years, this was the first time in their life that somebody listened to what they've had to endure with these persecutory auditory hallucinations for the last 30 years, which had been, slowly, eating away and disintegrating their sense of self-worth and value, just as we see with other trauma survivors. And that's on a background with horrendous bullying, which is just such a common experience for, many people presenting with psychotic disorders. So, I found that, perhaps like in other areas, that CBT, really just talking about the experiences and sharing that with people fostered feelings of control, reduced feelings of emotional distress and disturbance, promoted hope for the future, helped to build self-esteem, helped to challenge feelings of social, of no social worth and no social value, which often people have when they've got this level of impairment, helps to prevent relapse, but more importantly, allowed us to be co-journeyers in as they approach the life predicament of a life with psychosis. And often when we work with somebody with psychosis, we can be overwhelmed by the presentation. And yet that is absolutely no difference to how they're experiencing it as well. And creating a connection between you and them rather than a discontinuous thinking of they're sick and we're trying to get them help is so important. So you can see these contrasting approaches. You know, the traditional approach to thinking about psychotic symptoms is one of, you know, being silent, don't talk about the voices and delusions. The whole of the, you know, inpatient management is often a form of silencing, coercion, impersonal, highly stigmatized. They're passive recipients of their treatment. Their views and their desire for human rights are often not taken seriously. And there's this automatic assumption of wide-ranging disability. And this has been challenged by this other narrative, the consumer-driven approach, which is this open invitation for us as clinicians to discuss these symptoms and see them as a normal response to trauma and part of the human experience. To have a collaborative framework of formulation, collaborative goal setting, exploration of and reappraisal of what they're experiencing. To, you know, as co-witnesses of these experiences, we also get to help people interpret and understand the ongoing trauma they experience. And sometimes even to challenge some of their interpretations. There's other really important frameworks that we can think about drawing on. A very powerful therapeutic framework that's really emerged in a consumer-driven approach is this therapeutic paradigm called open dialogue. And this is a sort of a family and social network approach to working with people and families struggling with distressing and unwanted psychotic symptoms. And you'll see that this approach, you know, is now starting to be also used with people presenting with severe and chronic post-traumatic stress reactions because of it can be such a disabling long-term impairment. More recently, the third wave treatment, such as compassion-focused treatment for distressing voices, has started to emerge. And I also want to just bring back this sort of broader understanding of the triphasic, you know, treatments that many of us use for the more severe, you know, people presenting with very severe treatments, as we, you know, build a platform of stability initially so that we can journey with them as they try to come to terms with, live and move beyond their trauma and to develop independence and autonomy. These approaches remain equally relevant to, you know, this combined presentation of PTSD and trauma. So, you know, one of the key take-home messages is that why it's really important to recognize it, this is just part of the broad spectrum of trauma responses that people can have. And, you know, just this is from the Royal Australian New Zealand College of Practice Guidelines for Schizophrenia-related disorders. And just to show now, this psychological model is so well established that, you know, it's now considered to really be a failure of duty of care to not have them available for people. And so the notion once that you shouldn't do psychological therapy with people with psychosis, it's just is no longer accepted. But of course they note, and I'll come back to this, this has to be done in the context of people having access to evidence-based treatments for psychotic symptoms, and that's primarily antipsychotic medication and case management at times. Just in the little bit of time that I have left, I'd like to just also touch on this issue of the overlap between psychosis and disassociation. Now we know that both of them are, you know, well, especially many of us would work with people with very severe dissociative presentations, and that this is so strongly related to the severity of the trauma that I've experienced. You know, the functional understanding of disassociation as a way to disengage from overwhelming traumatic memories and content. You know, it's so well known to many of us. But when you actually look at people that have very severe dissociative conditions, there's an enormous overlap, in fact, with many of the symptoms that people with psychosis experience. So, you know, a recent review of 75 research studies found disassociation was very common in psychotic disorders. And we know in dissociative identity disorders that there are more Snyderian first-rank symptoms of schizophrenia than in many presentations of schizophrenia. So there isn't such clarity between these different domains. And I just want to show this sort of recent research looking at, you know, psychotic experiences and traumatic life events. And, you know, the association between trauma and psychosis is actually almost entirely mediated by dissociative experiences. So if we start to look at what is the mechanism that sometimes lies behind the journey to psychosis, there's growing evidence that dissociation is one of the mechanisms that lead into that path. So I just want to wind up with a few concluding comments. You know, the distinction between psychotic and other mental health symptoms has become less clear in recent years. The sense that you treat one with medication, you treat one with psychotic disorders, just isn't supported by evidence now. You know, the evidence that psychotic disorders, people that are experiencing psychotic disorders benefit from the kind of supportive psychotherapy that people without them is overwhelming, and it helps to reduce the intensity and severity of their psychotic symptoms. Severe and catastrophic trauma is associated with this increased risk to both dissociative conditions and psychotic symptoms. There's a very high prevalence of trauma exposure amongst people with psychotic spectrum disorders. And this evidence base, as I said, is that engaging with the meaning and the content of psychotic experience is a valuable and helpful exercise, because these are actually very re-traumatizing, just as intrusive reminders and flashbacks are terribly distressing. Now, all therapeutic work with people presenting with trauma-related dissociational psychiatric features, however, shouldn't be, you know, the sole practitioner is not the, you know, I don't think it's an overwhelming thing to take this on as a sole practitioner unless you're connected into a multidisciplinary team. Because the evidence is that no one treatment paradigm is enough. People need access to physical activity, to employment support, to vocational counselling, to family support, to psychological therapy. And it is essential that people are linked into psychiatric oversight, because we don't want to be depriving people of treatments that might relieve these symptoms. So it's absolutely essential that we work hand in hand with psychiatric oversight when we do work with somebody that presents with these symptoms. So I'm going to close this section of my talk now, and I'll hand back to Jorge.